Let me just introduce you, first of all, to my first speaker, Associate Professor Gabrielle Todd. Gabrielle is a neuroscientist practicing, specialising in the neural control of movement in humans. She leads the Neurophysiology Human Movement Group at the University of South Australia, and she has two large multidisciplinary teams with whom she leads with her research, which is focused on the early diagnosis and motor signs of Parkinson's disease, and also on the long-lasting effects of methamphetamine on movement. Just in October last year, as a result of Gabrielle's work, a public health campaign was launched, which highlighted the serious and debilitating effects of methamphetamine on the brain and the body. Such an important area and so prevalent, the methamphetamine epidemic. Gabrielle's research has been published in top-notch scientific journals. She's won a range of awards and prizes for her outstanding work. She's very committed to science communication, to the promotion of science in schools, and also to the wider community. So it gives me great pleasure to welcome Gabrielle to speak to us now. Thank you.
Thank you so much for that lovely introduction, and welcome everybody. Thank you for providing me with this opportunity to speak to you today about Parkinson's disease and our research. Before I start to talk about what occurs in Parkinson's disease, I'd first like to provide a little bit of information about how the brain normally controls movement. Now, many of the movements that we perform every day happen without us really having to think too much about them. And this suggests that movement is a simple brain function, but actually it's not. It's quite complicated. If you take this example here, the ability to grip and lift an object requires a grip force that must be enough to overcome the effects of gravity on the object and prevent it from slipping from our grasp. But our grip force can't be too large, otherwise it might damage the object that we're holding, or we could damage ourselves, or we may experience unnecessary fatigue. Now, when we go to lift an object that we've never encountered before, the brain must predict in advance how much grip force we're going to need to lift that object. And that prediction is based on the physical properties of the object and our prior experience with lifting similar types of objects. And the brain is also going to need to predict in advance what's going to happen during each phase of the movement. And all of these calculations and processes are occurring without us really being aware of it. Because of all of these processes and calculations that are taking place, the control of movement involves a large proportion of the human brain. Movement requires an awareness of where our body and our body parts are in relation to where we want to move to. And then we've got to select and create and implement the appropriate plan for that movement. And that plan has to occur at a really critical time. So because of all of these types of things that need to occur and the fact that we need to use so much of our nervous system for movement, if there's a problem with any one of those parts of the nervous system that are involved in movement, it can lead to what's called a movement disorder. Now, movement disorders are typically characterised by the types of symptoms that present. There's a wide range of symptoms, and some of those include an abnormally large tremor or shaking, rigidity, which is increased joint stiffness or muscle tone. Some people may experience tics, which are a type of repetitive or stereotyped movement or vocal noise that somebody can make. Other symptoms include problems with posture or with balance, walking, or even the speed at which people perform movements. Now, some movement disorders are characterised by just one or two types of movement symptoms, but other movement disorders have a whole range of movement symptoms. And sometimes those movement symptoms can overlap between different types of movement disorders, which can make it quite hard to differentiate one type of movement disorder from another. An example of a movement disorder that is characterised by lots of or multiple types of movement symptoms is Parkinson's disease. And Parkinson's disease is characterised by an abnormally large resting tremor, as well as rigidity. There's also problems with balance and posture and walking, and people perform movements at a slower than normal speed. Now, the cause of Parkinson's disease is not yet known, but it's thought to involve an interaction between environmental factors and genetic susceptibility. Some of the evidence that points to environmental factors comes from studying the disease processes and the way that the disease progresses through the nervous system. Some of the earliest signs of Parkinson's disease, or the earliest places where the disease is observed, is in the parts of the nervous system that are involved in our sense of smell and in the neurons that control our intestines. Now, these two places are where the nervous system interacts with the outside world through the things that are in the air that we breathe in and on the substances that are on the food that we eat. So because these two parts of the nervous system are where we see changes in the first instance, this is some evidence that points to potential role for an environmental factor in the cause of Parkinson's disease. After these particular parts of the nervous system become affected, we then start to see some of the disease processes occur in the brainstem, which is a part of the nervous system that's in between the brain and the spinal cord. Now, the brainstem has lots of different functions, but two of those functions that it's involved in are movement and sleep. So when this part of the brain becomes affected by the disease, people can have disturbances in their sleep, and it's also when they start to notice changes in their movement. And the reason that movement is affected is because there's quite an important region of the nervous system that is involved in movement, and that structure is called the substantia nigra. What happens in Parkinson's disease is that this particular brain region is the most affected region, and the hallmark pathology is loss of a particular type of neuron in this particular structure. And it's that change that really contributes quite a lot to the types of movement problems that people experience. Later in the disease can affect other parts of the brain, and if or when that occurs, people can start to have symptoms that involve changes in their cognition, memory and emotion. Now, in most people, the disease progresses very slowly over several years or even decades, and most people have had Parkinson's disease for 5 to 10 years before they start to notice changes in their movement. So it really is a disease that has quite a long course. Now, there have been several environmental factors that have been linked to Parkinson's disease, and I'd like to provide you with 3 examples of those today. The first involves exposure to a herbicide called paraquat. So paraquat is used to kill weeds, and its use has been now banned in over 30 countries, but it's still able to be used in Australia. Now, this chemical is quite toxic to neurons, and in particular, neurons that are found in the substantia nigra. They're particularly vulnerable to this chemical. Now, this chemical is so good at damaging the neurons in this part of the brain that scientists have actually used this chemical as an animal model for Parkinson's disease. So what I mean by that is scientists have exposed laboratory animals to paraquat in order to study what happens in human Parkinson's disease. So that's one example of an environmental factor. Another well-known environmental factor is exposure to the pesticide rotenone. Now, rotenone is also banned in several countries overseas, particularly in the European Union, and its use is restricted in the UK and in the USA. But again, it's still able to be used in Australia. Again, this chemical is quite toxic to neurons, and particularly to neurons that are found in the substantia nigra. And we can actually still buy rotenone products as members of the public from our local hardware store. This is a particularly toxic chemical, and it's been used by scientists in over 1,000 studies to study Parkinson's disease, actually several thousand studies, but it's been used as an animal model in over 1,000 clinical studies. So that's sought to try to understand more about what's happening in human Parkinson's disease. The last environmental factor that I'd like to mention is use of the drug methamphetamine, or ICE. This is an illicit or illegal recreational drug that's highly toxic, again, to neurons that are found in the substantia nigra. And methamphetamine has also been used as an animal model for Parkinson's disease, or to study Parkinson's disease. I'll be talking a little bit more about methamphetamine later in my presentation. The next thing that I'd like to talk about is how Parkinson's disease is diagnosed. Now, some of the earliest symptoms that occur in Parkinson's disease don't typically prompt people to go and see their doctor. It's usually only when the movement symptoms start to appear that people become concerned and go and see their doctor or their GP. And that then starts a long process of being diagnosed with Parkinson's disease. There's no definitive diagnostic test for Parkinson's disease, and most GPs will usually refer an individual that's suspected of having Parkinson's disease to a specialist, and in this instance it's a neurologist. The neurologist will then perform a diagnosis process to try to determine whether the person has Parkinson's disease or not. Now, for a diagnosis of Parkinson's disease to be considered, the person must have a type of slow movement called bradykinesia, and they must also have an abnormally large resting tremor or shaking at rest, or rigidity, which is that increased joint stiffness or muscle tone. They can have both of those, but it needs to be the bradykinesia and one or both of those other symptoms that need to be present. The neurologist will also look for other evidence that supports a diagnosis for Parkinson's disease, and an example of this is to trial use of a Parkinson's disease medication and see if the person responds well to that. If the medication helps to reduce the severity of their symptoms, then that's something that would support a diagnosis for Parkinson's disease. The neurologists will then also perform another whole big range of series of tests to try to rule out other potential causes of the Parkinson's disease and any other red flags that might point to a diagnosis of a different disease or a different disorder. This whole process can take up to a year to complete, and at the end of that, the neurologist really has three outcomes. Either to decide that the person doesn't have Parkinson's disease, they might have a different type of disease or disorder instead. Or the other two options are to conclude that the person has established Parkinson's disease or probably has Parkinson's disease. So this diagnostic process isn't perfect, and it does lead to a high rate of misdiagnosis, which can be of quite a concern because the types of medications that are used to treat Parkinson's disease are associated with common and significant side effects. Once a person receives a diagnosis for Parkinson's disease, at the moment the treatment and support options just seek to try to reduce the severity of their symptoms and to improve quality of life. Unfortunately, there isn't a cure for Parkinson's disease yet. My colleague and next speaker, Dr. Sue Sharrod, will be speaking more about the treatment and support options that are available for people living with Parkinson's disease and the challenges that people face. So just to provide a bit of a summary so far, Parkinson's disease affects many parts of the nervous system, not just the parts that are involved in movement. We don't yet know the cause of the disease, and there's no definitive diagnostic test, and unfortunately we don't have a cure yet for the disease. There is, however, an enormous research effort that's currently being conducted by researchers in Australia and overseas to try to address these knowledge gaps. And that research is really focusing on 5 broad themes: trying to get a better understanding of the disease processes that are occurring and how we can protect neurons from being affected by the disease or to limit how much damage is occurring. There's also a lot of research dedicated to trying to improve treatments and to find a cure. And there's also research that's being done on trying to identify individuals that are at risk or predisposed to Parkinson's disease, and then also how we can improve diagnosis and early detection. My research interests lie with these 2 themes: trying to determine who's at risk of Parkinson's and how we can improve diagnosis to make it more accurate and earlier than is currently possible. I'd like to speak about each of these research interests, and I'm going to start with risk of Parkinson's disease. So we can actually identify, even now, individuals that are at risk of Parkinson's disease using a technique called transcranial ultrasound. And what we use this technique for is to take a picture of the part of the brain that contains the substantia nigra. Now, for this technique, what we do is we take a standard ultrasound machine, one that would just be used on pregnant women, but instead of putting the probe on the abdomen, we pop it above the ear to take a picture of the substantia nigra. Ultrasound isn't designed to see through bone, but we actually get quite lucky in that when we place the probe above the ear, we can actually see in and look at the substantia nigra. And this technique provides us with a very cheap, inexpensive and accessible way of identifying individuals that might be at risk of Parkinson's disease. Now, if we were to take this part of the brainstem out, then it would look a little bit like this. So the top area of the brainstem has an outer edge that looks like the shape of a butterfly, and the substantia nigra appears as 2 stripes on the butterfly's wing. The reason that we have used ultrasound to look at this brain region is because we can't see it very well using normal MRI. Here is an MRI scan of this part of the brain that has the red line through it. Here's the front of the brain, the back of the brain, and we've got the right and left sides. In the centre, we can see a butterfly-shaped structure, which is the outer edge of the brainstem, but we can't see the stripes on the butterfly's wings, which are the substantia nigra. However, we can see the substantia nigra with ultrasound. So here's an ultrasound image, and this is where we held the probe above the person's ear. This big white band down here is the skull on the other side of the head, so we're literally looking between someone's ears. And then we can see a black butterfly-shaped structure in the centre, and now we can see a stripe on the butterfly's wing, which is the substantia nigra. And it's the appearance of the substantia nigra on this ultrasound image which helps us to identify people that are at risk of Parkinson's disease. When we perform this procedure on people that are living with Parkinson's disease, 90% of people that have Parkinson's disease have a change in the appearance of the substantia nigra. And that change is an abnormal or increased area of bright signal that's in that brain region. Because 90% of patients have that change, it's actually being used in some countries, like Germany, as a diagnostic aid for Parkinson's disease. It's not a standalone test, but it's one of those supportive tests that can help a neurologist to reach a conclusion about whether somebody has Parkinson's disease or not. Now, interestingly, 9% of healthy older adults also have this brain change. And there's been a lot of research on these individuals to work out what that means. And from quite large studies that have been done overseas, we know that when healthy older adults have this same change that people with Parkinson's disease have, then we know that that's associated with significant risk of developing Parkinson's disease. One of the studies showed that had 1,300 participants in it, that people that had that ultrasound change were 17 times more likely to be diagnosed with Parkinson's disease over a 3-year period compared to people that didn't have that brain change. So it really is quite a considerable risk factor for Parkinson's. I'm interested in what else is happening in these at-risk individuals. So are there any other changes that are occurring in these healthy older adults that have the same brain change that people with Parkinson's disease have? We've done a series of studies in this area, and I'd just like to talk about one of them today. In this particular study, what we did is we had 2 groups of healthy older adults. One group had a normal-looking substantia nigra, and the other group had the abnormality, so the abnormal appearance in the substantia nigra. And what we asked these 2 groups of people to do is to grip and lift an object. And this object was fitted with sensors that enabled us to collect lots of different types of data that informed about how people were planning and performing movements and how they were learning and adapting their performance to optimise the way that they were performing the task. Here is some data from 2 individuals, one from each group, and we saw 5 differences all up between these 2 groups of individuals, and 4 of those differences were also seen in people that have Parkinson's disease. One of the differences that we observed in people that had the abnormal substantia nigra is that they overestimated how much grip force that they needed to grip and lift this object. So that was indicative of having some problems with the way that they were planning their movements. And so 4 out of the 5 changes that we saw resembled what we see in people that have Parkinson's disease. And the data from this study supports that this brain change that we can see on the ultrasound is a significant risk factor for Parkinson's disease, and people that have this change that haven't been diagnosed with Parkinson's yet do have subtle changes in their movement that resembles Parkinson's disease. So this technique enables us to identify people that are at risk, but it also provides a way that we can potentially study people that are in the early stages of the disease before they've been diagnosed. Now, there's a particular group of at-risk individuals that I'm very much interested in, and that is young people who have used the drug methamphetamine or ice. Australia has a really big problem with this drug, and as I mentioned earlier, it's very toxic to this region that's very important for movement. What we did in this study is we had a look at the appearance of the substantia nigra in young to middle-aged adults that had used methamphetamine before, and also in 3 other groups of people that were acted as controls. One group had never used illicit drugs before, one group had used ecstasy but no methamphetamine, and the other had used cannabis but no ecstasy or methamphetamine. And the reason that we had these other control groups is because if we did see a change, we needed to be able to identify which drug was likely the problem drug. And in this study, that problem drug was methamphetamine. What I've got in this graph is showing the area of bright signal that was in this brain region when viewed with transcranial ultrasound. And only the group that had methamphetamine had an abnormally large area of bright signal that wasn't observed in the other control groups. And this is the same change that we see in people that have been diagnosed with Parkinson's disease. So that what that tells us is that young people that have used methamphetamine are at much greater risk of developing Parkinson's disease later on. Now, what was quite frightening with this is that we saw this brain change, which is very long-lasting, in people that had only used the drug as little as 5 times in total. So this is not something we saw in people that had been addicted to methamphetamine. It was even present in people that had only used it very infrequently, as little as 5 times. We then wanted to see, well, okay, these people are at much greater risk of developing Parkinson's disease, but do they have any early signs of Parkinson's disease? So what we did is we asked a neurologist to actually have a look at these individuals and how they were moving, and we asked that neurologist to perform a Parkinson's disease symptom severity rating scale on all of the participants in this study. So what this rating scale is doing is essentially asking, are there symptoms of Parkinson's disease present and how severe do they appear? And it was focusing on the movement symptoms. We didn't tell the neurologist which group the participants belonged to, so it was an unbiased rating that was provided. And over here is the score that people received on this Parkinson's disease symptom severity rating scale. So the people that had used methamphetamine before averaged around 8, and this is compared to less than 4 for each of the control groups, which have all been pulled together in just one bar. So what this data shows is that people that have used methamphetamine before have significantly more symptoms of Parkinson's disease in terms of their movement compared to people that haven't used methamphetamine before. Now, the numerical value that was achieved was quite clinically relevant because if we have an older person that has Parkinson's disease that's only just been diagnosed with it, hasn't started their treatments yet, that person would typically score between 12 and 16 on this rating scale. And these young people that had used methamphetamine, some of them were approaching that value already. So using methamphetamine is associated with long-lasting changes in this brain region that resemble Parkinson's disease, and they already have subtle changes in movement that also resembles Parkinson's disease. Now, this is quite a concerning finding because 1.3 million Australians have used methamphetamine, which is a huge number when you consider that the total population of Australia, including babies, nanas and everyone in between, is 26 million. So it really is a significant problem. And we don't yet know what effect that using methamphetamine in the current generation of young people is going to have on the prevalence of Parkinson's disease in the years to come. As these young people age, we're expecting to see an increase in the prevalence of Parkinson's disease as a result of use of methamphetamine when they were younger. Now, as mentioned earlier, we have translated our work in this area into a public health campaign that was launched by SA Health in October. That campaign ran for 4 months and it targeted young people. The ads, actually young people were bombarded with ads on social media, online gaming platforms. The ads were in pubs and clubs, and they were also on pizza boxes. So any sort of mechanism that we could think of that could reach young people, we tried in this campaign. The campaign was a collaborative effort between researchers at UniSA and SA Health, and in particular the Drug and Alcohol Services South Australia, which is the drug and alcohol section of SA Health. The campaign was also supported and made possible by the Hospital Research Foundation Group Parkinson's, and we also partnered with the South Australian branch of the Australian Medical Association. So this campaign really sought to raise awareness of this issue among young people. The catch line was "Don't let meth take hold," and then the key take-home message was taking methamphetamine, even a few times, can impair your brain and movement for life. We're currently evaluating the efficacy or how effective that campaign was at the moment, and we're hoping to do a second phase of that campaign in the middle of the year. So that's a bit of a summary about my research that aligns with identifying risk and predisposition to Parkinson's disease. I'd like to spend the last few minutes talking about my other research interest, which is improving diagnosis and early detection. And this research also involves focusing on the appearance of the substantia nigra. For this, though, we're using a new type of MRI scan that does enable us to see the substantia nigra. I mentioned before we can't see it with standard type of MRI scan, but with new types of MRI scan we can see the substantia nigra. This is one of those new types of MRI images. Here's the front of the brain, the back of the brain, and the right and left sides. The butterfly-shaped structure in the centre is that outer edge of the brainstem. Again, remember the stripes on the butterfly's wings are the substantia nigra, and now we can see the substantia nigra on this type of MRI image. I'll just magnify that a little bit further here. So here's the outer edge of the brainstem in yellow, and the substantia nigra appears as a stripe of dark signal and light signal on both sides, the right and the left side. And this is what the substantia nigra would normally look like on one of these MRI images. This is what the substantia nigra looks like in a person that's living with Parkinson's disease. The main change that we see is loss of the white areas of signal in this brain region. And this change has actually been proposed to be a diagnostic aid for Parkinson's disease, because we see this in about 90% of people that have Parkinson's. However, there's a bit of a problem for actually using it widely in clinical settings. And the problem stems from the current method involves a subjective judgment about whether the substantia nigra looks normal or not. And this is made by a radiologist. And so really the radiologist just has to look at the image and decide whether they think it looks normal or not. This is quite hard to do because radiologists don't get an opportunity to see many normal-looking substantia nigras, because most of the people that are referred for this type of imaging are suspected of having Parkinson's disease. So this is a little bit of a barrier for widespread use of this type of imaging in the diagnosis of Parkinson's disease. A potential solution to this problem is to develop an easy and objective method for radiologists to use so that they don't have to rely so much on judgment anymore. And then to characterise what the substantia nigra normally looks like, so we can provide radiologists with a reference standard to compare against when they're assessing a patient that has suspected Parkinson's disease. And that's exactly what my colleagues and I are working on at the moment. So we are actually have just finished the data collection phase of quite a large study that aimed to quantify the MRI appearance of these substantia nigra using a new and simple objective method that we developed. We scanned the brains of 105 people that don't have Parkinson's disease that were aged between 18 and 80. And we also scanned the brains of 39 people that were living with Parkinson's disease. What the preliminary findings are telling us at the moment is that we don't see any difference in the appearance of the substantia nigra between males and females when viewed with this new type of MRI image. And we don't see any difference between the right and left sides, and both of those are good things. However, we do see a change in the appearance of the substantia nigra with age, and that's important to know because what that means is that we need to provide radiologists with age-specific normative data to compare patients to. So that's quite an important finding that we've already made from this study. The other thing that we're looking at is the relationship between the appearance of the substantia nigra on the MRI image and how people are functioning in terms of their nervous system function. We're particularly focusing on movement, and we're having everybody that had one of these MRI scans is going through a big series of other tests. A lot of those are on movements, both with a neurologist and in our laboratory. We're also doing speech tests because speech is a very specialised form of movement. And we also have asked people to do a series of memory and cognitive tests as well to see how it relates to those sorts of functions. We also actually had people undergo one of those transcranial ultrasound images as well to compare the appearance of this brain region on those two different imaging modalities. And the data that we obtained from those two imaging modalities is correlating quite well. So when we see something abnormal on the ultrasound, we also see an abnormality on the MRI, which is also very encouraging for use of potentially using this more widely in clinical settings to aid diagnosis of Parkinson's disease. Now, many of the studies that I've been talking about over the last several minutes have involved a large team of researchers, and I'd like to finish my presentation today by acknowledging all of those members of the teams that have contributed to the findings that I've been talking about today. I would also like to acknowledge the different organisations and individuals that have supported our research over this very long journey that I've been working in the area of Parkinson's disease, and also the many people that have volunteered for our studies, because without the support and the volunteers, this sort of research isn't possible. So thank you very much for your attention, and I'm more than happy to answer any questions that you may have. Thank you.
Thank you very much indeed, Gabrielle, and I know that somebody will come with a mic and will come near you when you ask a question so everybody can hear it. There's one right up the back.
Good exercise during this. Thanks so much. Hi. When I was 12 years old, and I'm 66 now, I was diagnosed with dystonia. So my hands shake a lot and it's gradually getting worse. And so I was just curious, is that something entirely different to Parkinson's? Or am I possibly one of those susceptible people who might, eventually start getting symptoms, since it's largely my hands I notice and maybe, a bit of tightness in my muscles. So, is it, something that has some connection to Parkinson's at all?
So thank you for your question. Dystonia is a different type of movement disorder. And one of the most characteristic features of dystonia is a sustained abnormal contraction of a muscle. And so that some of the symptoms differ between those two different types of movement disorders. And some people can be unlucky and end up having both. But not everybody will be in that vote, but they are two separate movement disorders because they have two separate sets of symptoms in most people.
Hi, thank you for a fabulous presentation. That's great. I am just wondering, in your research in regards to ice usage, you looked at those who had only used the drug very few times. Did you look at the length of time after? I'm just wondering if there's a time of recovery or whether, in fact, once you've used it, that's it, done.
Yeah, that's a great question. The people that we were most interested in testing in that particular study were people that had stopped using methamphetamine a long time ago, so that the last time that they'd used the drug was months to years beforehand. Because what I'm interested in is what those people are left with as a result of their previous use. So I think from memory, the average duration of abstinence, so how long ago people had last used, was about 2 years in that particular study. So we think that the damage that drug does is quite long-lasting. Not all of the damage that drug does is long-lasting. There are other types of damage to other types of neurons that can undergo some recovery. But what we observed in the substantia nigra is quite long-lasting. We can never say permanent because that's not a word you're allowed to use in science so much. But I'd just like to provide an example of what I mean by long-lasting, in that there are several hundreds of thousands of people across the world that have had that ultrasound image of the substantia nigra, and there's never been one reported instance where somebody has had an abnormality and it's gone back to normal. So I can't say that it's permanent, but we say that it's long-lasting because we just haven't collectively across the scientific publications observed anyone that's gone from having a normal substantia nigra back to, an abnormal substantia nigra back to a normal one.
Questions at the front. I see if I can take some of those.
I might have missed this, but does Parkinson's have a hereditary component?
That's a fantastic question, yeah. So about 15% of people who have Parkinson's disease have a family history of Parkinson's, but the other 85% of cases don't have a family history. Genetics do play a role in the disease, and for some people, they're genetic mutations that are passed down through families, and for other people, they're genetic mutations that occur within their own lifespan.
Yes, thank you. There's a lot of children that have been diagnosed with ADD and have been prescribed dexamethasone, and kids, my son, and he's been on it for quite a long period of time. I'm just wondering, is there any research looking at effects of that drug?
That's a fantastic, yeah. So ADHD, or attention deficit hyperactivity disorder, that can be treated, there's probably 3 main types of medications that are used to treat that particular disease or disorder, and one of those is called dexamphetamine, which is quite a popular form of treatment. Dexamphetamine is just amphetamine, of which is very similar to methamphetamine. And so, quite rightly, you could ask the question, well, if we see this in people that have used methamphetamine, will we see this change in people who are using dexamphetamine to treat their ADHD? We actually asked that same question because it's a very good one. And we did a study on children that have been diagnosed with ADHD. We had 3 groups of children in that study, children that didn't have ADHD, and then 2 groups of children that did have ADHD. One group of ADHD children had never been medicated before, and the other group had been medicated before. Now, we were expecting to see this ultrasound change in those children, and we did, but it was complicated because we did see it in both sets of children that had ADHD, ones that had been medicated and ones that hadn't been medicated. And in hindsight, that wasn't so much of a surprise because that particular condition involves dopamine, which is the same type of neurochemical that's involved in Parkinson's disease. And so those 2 different disorders are affecting the same type of neuron in the brain that release dopamine. Now, we didn't have enough children in each group to see whether the 2 sets of children differed from one another in terms of the appearance of the substantia nigra. And we also ran into the other complication in that we couldn't standardise disease severity between the 2 groups of ADHD children because usually the ones that haven't been medicated because their symptoms aren't as bad. So they have a lower severity of the disease compared to people that have been medicated. And so it wasn't an easy study to do, and we couldn't actually answer the question that we sought to answer from it. But our research other research that's been performed in animals on methamphetamine suggests that it's the dose that is the critical factor, and that if you just look at amphetamines as a class of drug, when it's used recreationally, it's used at a higher dose than when it's used therapeutically as a medication. So what animal research shows is that there's a dose, the dose is the key factor. The higher the dose, the more damage that is induced, and those doses are more likely to be used by people that are using the drug recreationally. Another thing that points to that potentially it's not so much of a problem with dexamphetamine is that we didn't see any correlation in our people that use it recreationally between how many occasions of use and the severity of the abnormality that we saw. If we had seen a correlation between those two, it would suggest that with each additional dose that you have of methamphetamine, then you're damaging the nigra more and more, which means that you would end up with a worser looking substantia nigra at the end. But we didn't see that correlation, which that also suggests that dose is probably the problem with the methamphetamine. And that also supports why we see these changes in people that have only used it 5 times. If one of those or 2 of those times was at quite a high dose, then it's the dose that's likely to induce the damage. So the answer to your question is it's not certain yet, but my feeling is that the doses that are used therapeutically for treating ADHD are unlikely to produce as many of the problems that we see in people that are using methamphetamine because they're at a lower dose.
Zoe, can we manage two more questions, do you think?
Thank you very much for an excellent and very informative presentation. I saw an article recently that stated that Parkinsonism is the most rapidly increasing neurological disease across the world. And also the authors posited that maybe carbon tetrachloride or a similar chemical used for dry cleaning may have a role in it. I wonder if you'd care to comment.
I'm not familiar with the literature on that particular chemical, unfortunately, so I can't provide a response to that. There are a lot of environmental factors or exposure to particular chemicals that have been implicated in Parkinson's disease. I would say that there would be several dozen, but I'm just not familiar with that particular one, unfortunately.
One more question, I think.
After hearing your beautiful speech and everybody else's questions, I feel a bit silly asking this question. So I was wondering, since there's no cure, why would anyone, unless they had really severe symptoms, why would they get diagnosed before they needed to? Because that would affect their emotional work life. I was thinking of myself. If by the time I decided something's not right with me, I don't think I'd do it straight away, because then the stigma would be on me. I might lose my job. I might make myself even more sick. So why would anyone do that?
That's a great question. A lot of the new drugs that are being developed, new medicines that are being developed, not only for Parkinson's disease, but for other types of neurodegenerative disorders like dementia and Alzheimer's, a lot of those are focusing on trying to protect surviving neurons. So that if you can protect and put a fence around the neurons that haven't been affected yet, then the disease doesn't necessarily need to progress in terms of the symptom severity as it normally would, because you're protecting the ones that aren't affected yet from succumbing to the disease. Now, those sorts of medicines work best if we can diagnose people as early as possible. Because then, if you can get a person diagnosed very early, when the symptoms are only very subtle, then we have the potential of keeping them at that point and for the disease not to affect them as much any further. They still have the problems that are there present when they're diagnosed, but they might not progress to the really severe symptom severity that they may do had they not had these new generation of protective drugs. So there's an enormous opportunity to utilise those for Parkinson's disease if we can shift the diagnosis point earlier and then provide people with a better quality of life moving forward than if the diagnosis was later and then their symptoms may get worse over time.
We have run out of time. I will be thanking both speakers at the end of the afternoon, but I do want to say, and echo some other questioners as well, what clarity and such great information, and so very topical and relevant to today. Gabrielle, thank you very much indeed. We now break for afternoon tea.
outside, and we'll see you back here in a quarter of an hour. Thank you very much.
Dr. Sue Sharrard is a nurse consultant of a good number of years of experience. And I know when you hear from her, you'll realise just how committed she is to the topic of Parkinson's disease and such enthusiasm and grounded knowledge she'll bring to her presentation. Dr. Sharrard has got two clinical areas of speciality. One, of course, is Parkinson's disease nursing, and the other one is intensive care nursing. She's very committed to the education of nurses of the future, not only undergraduates, but also postgraduate nurses as well. And most importantly, and I think so significantly, her research interests are motivated by improving the lives of people in regional areas. And so not only is she doing some really valuable and practical work in relation to Parkinson's disease in regional areas, but also was funded for a research grant for developing a stroke coordinator role for regional areas. So these are areas, stroke and Parkinson's, which are so incredibly important. Sue's also involved with Parkinson's disease support groups and shares her expertise, speaking wherever she can, but particularly to regional community groups. So it's with great pleasure that I invite you to welcome Sue to speak to us today. Thanks, Sue.
Now, I'm going to try and be still so that you can hear me very well. Thank you to the organisers for inviting me today. And as has been mentioned, previous to my appointment here at UniSA, I was a nurse consultant for Parkinson's disease. I did work across the 6 regional local health networks with people who were living with Parkinson's disease. So that might have been one of the reasons why I was afforded this opportunity. I'm hoping that my presentation complements what's already been provided to you today by Associate Professor Gabby Todd. And what I'm going to talk about is things around the prevalence of the condition. I'm going to spend a little bit more time talking about the symptoms, both the motor and the non-motor symptoms that are associated with Parkinson's disease now. Spend a little bit of time talking about how to live well with Parkinson's disease, and then discuss very quickly my research projects that I'm involved in, because we're at the beginning of our journey. So it's been mentioned from the audience already, but Parkinson's disease is actually considered to be the fastest growing brain condition in the world. It's growing faster than Alzheimer's, it's growing faster than stroke, it's growing faster than epilepsy, and it's growing faster than motor neurone disease. And some of those are high-profile conditions that you hear about a lot more frequently than you hear about Parkinson's disease. And what you can see on this graphic is that the number of people worldwide who are living with Parkinson's disease between 1990 and 2015 virtually doubled, and what we're expecting to see is that between 2015 and 2040 that number is going to be more than double again. We think that age might be a factor related to that increasing prevalence, but as has also been mentioned from the floor, exposure to the use of pesticides, other chemicals, exposure to air pollution and heavy metal exposure might be other contributing factors for this increasing prevalence. You've heard already from Associate Professor Todd's presentation, it is a really complex condition. It's complex, it's chronic, it's slowly progressive, but importantly, it is highly debilitating, and I'm not sure that the general population understands that particularly well. One of the other factors I think that this slide might imply that's not particularly obvious, and that is the burden that's going to be associated with this condition, not only for the people who are living with it, but for our communities and certainly for our healthcare systems as well. So let's talk a wee bit about local prevalence. In 2014, we determined that it was a highly prevalent disease, and it was actually considered to be more prevalent than some of the other conditions which at the time were determined to be national health priority areas. Things like some of the cancers, breast, colorectal, uterine, lung cancer. And at the time we were kind of citing that we believe there's about one person in every 308 Australians who are living with Parkinson's disease. But that number is a bit tricky to verify. We had a report that was released in 2015 and it was produced by Deloitte Access Economics, and at the time they said, in the time period just before the release of their report, there might have been about 84,000 people who were living with Parkinson's disease across Australia. A more recent publication in 2018 by Ayton and their colleagues suggested actually that number might be closer to 212,000. So there's a significant difference there already. Now, most people consider Parkinson's disease to be an older person's condition, and perhaps that's related to the fact that the average age of diagnosis is about 65 years. But what we know in Australia is that 10% of the cohort that lives with Parkinson's disease is aged less than 45 years. Approximately 18% of that cohort is still of working age. So the impact of the condition for that volume of people is absolutely significant. Currently, Parkinson's Australia, who's the peak organisation for Parkinson's disease, suggests that 37 new cases of Parkinson's disease is diagnosed every day. And worldwide, we know that the population that's aged over 65 years, 2 to 3% of those people are living with Parkinson's disease. But critically, what we know too is that 50% of people who are living with Parkinson's disease do not ever get diagnosed. And perhaps that is related to the complexity of diagnosis that was explained in our earlier presentation. We do not have the definitive test, and as was described, it takes for someone with clinical expertise to make that judgment. So what about the costs then? When Deloitte Access Economics published that report back in 2015, they suggested that the cost associated with Parkinson's disease was $10 billion. Now, the groups that bear the cost of that is people who live with the condition, their carers, employers due to lost productivity for that group who is still attempting to work, federal, local and state governments that are attempting to provide services for people living with Parkinson's disease, and the rest of society, non-government organisations, workers' compensation groups, non-profit organisations, people like that. So, in our previous presentation too, there was talk about symptoms presenting before diagnosis. So what we learn from this slide is lots of things. The condition is extensive, it goes over many, many years, and it goes through a variety of different phases. The phase that occurs, have I got my pointer? Yeah. Here we have the onset of motor symptoms that was described previously. Here we have a set of conditions, a set of features that might be presenting in a phase before Parkinson's disease is diagnosed. Things like REM sleep behaviour, that is when people vividly act out their dreams. Depression, Constipation. Now reflect back on our previous presentation where we said the pathology of Parkinson's disease is attached to the nervous system of the bowel. And anxiety. So this phase, in the literature, there's a changing viewpoint around this. Once upon a time they were saying, you know, this phase before the condition is diagnosed might be 10 years. Some people are now suggesting it might be 20 years. Some people suggesting it may be longer. And people who are living with these things are putting them down to other things. Maybe it's ageing, maybe it's their stage of life, maybe what's happening personally. So they don't figure them as part of Parkinson's disease. But at some point, a motor symptom is going to appear, and very often what I see is that's the thing that prompts the person to seek medical help, that initiation of a motor symptom. But what else is significant on this slide is that there are many symptoms now that are associated with Parkinson's disease. There are many of them that accumulate across the journey with Parkinson's disease and across the phases of the condition. And as they accumulate, what this graph tells us is the degree of disability that occurs for the person who's living with the condition, that is increasing the longer you have the condition as well. So here, on one slide, I have poached from one of Parkinson's disease best experts their snapshot of what Parkinson's disease is. So in our previous presentation, we learnt about the 4 motor signs, and most people would recognise this more than anything else. There is bradykinesia, slowness of movement, or akinesia, which is described as a lack of voluntary movement. There may be stiffness or rigidity. There is certainly gait and balance disturbances, and there is a tremor, a typical pill rolling tremor that is experienced at rest. 30% of people who have Parkinson's disease may not present with the tremor, and as has been previously mentioned, for diagnosis, at least 2 of these motor symptoms have to be present. But on the other side of the slide is the non-motor aspects of the condition, and there are 10 times as many non-motor symptoms that are now directly attributed to Parkinson's disease and what is occurring in the brain. And if I was to talk to someone who's living with the condition and describing this at the beginning of their journey, I'd break these into 3 distinct categories. One we call the neuropsychiatric category, the mood changes that are experienced or may be observed, things like depression, things like anxiety, things like apathy. Then there's a whole series that you'll see on this slide that may be connected to the use of the medications. The other one would be around sleep. So we've talked about the REM sleep disorder, the acting out of vivid dreams, but there's excessive daytime somnolence as well. There is trouble falling asleep, and there is trouble staying asleep. And the third significant category relates to changes that occur in our autonomic nervous system. As mentioned in our previous presentation, that part of the nervous system that governs all the things that we don't actually think about doing. So things like controlling blood pressure, things like controlling urine, things like other normal autonomic functions that occur in the body. Now, what I know, or what the literature tells us, is that people who live with Parkinson's aren't as perturbed with their motor symptoms as they are perturbed by this constellation of non-motor symptoms that they experience. And during that long journey with the condition, the literature tells us that they will experience 9 to 12 of these, and they may in fact come in and out of that journey. Reflect back on how they were accumulating in our previous slide. So, management for the condition. Management is aimed at controlling the symptoms that are experienced by the person, and what we aim to do is replenish one of the missing chemicals. Associate Professor Todd showed you those pictures of the substantia nigra and showed you those little black strips. Those little black strips have specialist nerve system cells in there that produce a chemical called dopamine, and that's the significant chemical that's lost in Parkinson's disease. So what we aim to do is use several different medicines to help replace dopamine in the body that is not being produced by the person who has Parkinson's disease. Now, for that, clearly, specialist medical attention is going to be required for the prescription of those special medicines. However, problem in South Australia. Some of you may have experienced it if you're in the audience and you live with Parkinson's disease. You're going to go to your GP and say, there is a problem. If your GP suspects that Parkinson's disease is something that needs to be investigated, they're going to send you off to a neurologist. But the wait for your first appointment with a neurologist may be significant. It may be months, it may even be a year. So there is that time frame where you're waiting for your diagnosis and attempting to manage a condition which we now know can be particularly burdensome. So when whatever is prescribed for that person who's living with Parkinson's disease, it will be prescribed uniquely to them because it is based on the way that they're experiencing the condition. And for people like me who work with people living with Parkinson's disease, one of the things we say is that no two people will ever experience Parkinson's disease in exactly the same way. So we attempt to tailor our management to the medications to combat your symptoms, the way the person is going to respond to those medications as well, and the stage of the condition. Now, please forgive me here. I'm going to spend a minute trying to explain how those anti-Parkinson's medicines work. It's a really rudimentary diagram. Imagine this as one of those cells that's sitting in that where those black strips should be, right? What we've learnt is there are cells that die there, and there is dopamine not being produced by those specialised cells anymore. We're aiming to utilise medicines to promote the presence of dopamine so that we can combat the symptoms that the person is experiencing. So this is supposed to be a rudimentary nerve cell. What you can see here is ordinarily in our body what happens is there's this essential protein, and it's called an essential amino acid that's called tyrosine. And it would normally in this cell get converted to levodopa, and then it undergoes a little bit of chemistry and produces dopamine that then is utilised by the nervous cells. First it gets packaged in these little vesicles. Once the nervous signal gets transmitted via these specialised cells, it tips dopamine, these little purple, represented by these little purple dots in this space between the nerve cells. It gets picked up by the next neuron, and that message keeps getting passed along, beg your pardon. So that's what should normally happen, but not happening in a person with Parkinson's disease because these cells have started to die off. So what we do is use the oldest, this drug is about 50 odd years old now. It's a medication called levodopa, same sort of substance that is included here. We administer medication called levodopa orally so it can cross this blood-brain barrier, make its way into the nervous cell, get converted to dopamine, and therefore we can have some way to respond to the symptoms that are being presented. The second group of drugs, and it's a very long and complex name, you don't really need to worry about it except for this. What happens is there's this special chemical called COMT that exists in the periphery, and it also exists in this nervous cell. If it has an opportunity to act on dopamine, it will render it a more useless substance. What we want to do is use a medication that inhibits its action so that we can optimise the amount of dopamine that's available for that person with Parkinson's to use. Therefore, we can make a difference to their symptoms. The next substance, there's a substance called MAO-B. It is another enzyme that exists here in the neuron, and it exists here in this little synapse, in this little space between the nervous cells. It too is a substance that can act on dopamine, change it so that it's not as useful to the person with Parkinson's disease. So there's a class of medicines that inhibit its action so that the volume of dopamine available for use is optimised. Dopamine agonists. This is one of the fourth class that's typically used. It is a substance that has a very similar chemical structure to the dopamine that's not being produced anymore. But what it does is latches onto this, what we call a postsynaptic neuron, because it's on the other side of the synapse, and it enables the nervous system messages to keep being transmitted. Now, a point here. All of these medications have potential to cause impulsive and compulsive behaviours in the person who take them. So that requires vigilance from the medical team. Yeah? But out of all of these medications, the dopamine agonist might be the one that is more likely to initiate impulsive and compulsive behaviours. Yeah? It's one of the things that's very scary for the person to talk about with their care team. The last medication is a drug called amantadine, actually an antiviral medication, but it's found to have some utility because what it does is shut down these little receptor passages, and so therefore the amount of dopamine that would normally be taken back into the cell is prevented from doing that, and therefore the amount that's available for use is optimised. So in summary, we have 5 different classes. We have levodopa replacements, medications like levodopa and carbidopa, levodopa and bensericide. For people in the audience who live with Parkinson's may recognise some of these. COMT inhibitors like entacapone, MAO-B inhibitors like rasagiline, dopamine agonists like pramipexole, and others like amantadine. Now, these medications may be used by themselves or they may be used in combination. And certainly as the disease progresses, it is more likely that the classes will be blended together to help manage the symptoms that the person is experiencing. What we notice too over a period of time is that the doses, the frequencies and the amounts might change to accommodate fluctuations in the symptoms that a person with Parkinson's disease lives with. The thing of note for people who are in the audience and live with Parkinson's disease, there are many other medications that should never be mixed with anti-Parkinson's medicines, and we have evidence to suggest that even healthcare clinicians don't understand this well. So one of the things that might put people at risk who are living with Parkinson's disease is inappropriate medications being prescribed that either potentiate the action of their anti-Parkinson's medications or are contraindicated and remove the action of their Parkinson's disease medications so that their symptoms get worse. That's something people need to be aware of. Okay, another form of management is what we call the device-assisted therapies. So there are 2 things that you can see up on this screen. There is 2 types of infusions that can be administered. If we focus on this first one too, there is a gel of levodopa that can be produced attached to a pump that is infused over the better part of a day. Often people will wear these pumps for up to 16 hours in a day. What you notice here is this person has had a special tube inserted through to their stomach through through their skin, and through it is a longer tube that's passed, and it's fed all the way through to a section of the small bowel so that that medication can be delivered to the site where it's absorbed. It is used as a management strategy when the symptoms start to fluctuate, and sometime usually later in the condition. This other form is, you can see a little needle, a tiny little needle is inserted into subcutaneous tissue. It is connected to a syringe full of a medication that's called apomorphine. Apomorphine is from the dopamine agonist group, and therefore that person again has an infusion, a continuous but slower form of the medication administered during the course of the day, again probably up to about 16 hours. Lastly, we have deep brain stimulation. So in deep brain stimulation, what happens here, an invasive procedure, there are electrodes that are placed into the person's brain that are quite specific targets. They end up in quite a specific spot. They are connected with a set of leads to a little battery pack that sits just underneath the skin, and little parcels of electricity are administered directly to those particular parts of the brain as a means to help manage the symptoms associated with Parkinson's disease. This is a surgery that's offered in South Australia, and there are quite good outcomes for this surgery here, but not everyone who has Parkinson's disease qualifies for this surgery, and there is a particular set of eligibility criteria that has to be met by some very formal assessments that are conducted by healthcare professionals to ensure that that person is eligible for the surgery. Now, if the person is ineligible for the surgery, it's probably related to the fact that the risk of having the surgery is going to outweigh the benefits. A little word about misinformation. Often when I meet people who are living with Parkinson's disease, they've done a whole pile of investigation, thank you very much, about what might be useful to them and living with the condition. I have to be really fast now. So they head to the internet. There's a plethora of information about the use of supplements and other substances. Just be very mindful that it doesn't necessarily have the evidence base. And some of the supplements that are actually suggested by those sources for the management of Parkinson's disease aren't regulated by the same agencies that would normally regulate medication. So we've got no sense of dose, no sense of purity, no sense of those sorts of things, which may be actually risky for the person to be involved. If you're in the audience and you're living with Parkinson's disease, what's my tip? Never swap out your medications for something without discussing it with your medical team first. I get a lot of questions too about the use of cannabinoid-based medications. To date, we haven't got any conclusive evidence about this. The studies are appearing inconclusive. So what we need is some larger studies, larger groups of people being studied, specific targets being measured. So just be mindful of that. So I've told you where not to go for information. I guess it's only fair that I tell you where to go for information. And here are a number of different options that might be useful. The Parkinson's Research Foundation Group Parkinson's, Parkinson's Australia, Parkinson's UK and Parkinson's Net have lots of information. It is based in evidence, but what you'll find is that it is documented in a consumer-focused way. So how is Parkinson's disease managed? Parkinson's disease, we don't have clinical practice guidelines in Australia for Parkinson's disease management, but some exist internationally, and they provide the basis of what could be the care provided by healthcare systems and socially for people living with Parkinson's disease. And what these guidelines suggest is interdisciplinary care should be advocated for people with Parkinson's disease, and it's certainly one of my areas of research interest. Locally, what we have is SA Health has produced this online portal for other healthcare clinicians, people like GPs or other healthcare clinicians, to seek evidence-based information. So what does it take to live well? I showed you that big slide. One of the things I didn't mention when I mentioned the Parkinson's disease medications is some of them will have some utility against the non-motor aspects, but most of the medications that are used have no utility for the non-motor aspects of the condition, which is most burdensome to a person who lives with Parkinson's disease. So in that case, and as is experienced overseas, an interdisciplinary team is necessary to help you manage what Parkinson's disease brings you. And so we have the consultant neurologist to help prescribe the medications. We have specialist Parkinson's disease nurse, dietitians for the nutrition, podiatrists for mobility, pharmacists to make sure that you're taking your medications correctly and no other contraindicated medications have been prescribed, psychology for the neuropsychiatric features, social worker, speech pathologists, physiotherapists for mobilities, occupational therapists for functional abilities. In reality, it might be that you get to have 1 or 2 appointments a year with your specialist neurologist. So the relationship that you build with your GP, and if you can access a Parkinson's disease nurse specialist, they are critical members of an interdisciplinary team and can certainly hold the team together. I told you about some of the misinformation, but where there seems to be emerging evidence is in the benefit of exercise. And what is being suggested is 2.5 hours of moderate intensity exercise. This is a picture here of a well-known Parkinson's disease expert from the Netherlands. His words were, "It has to make you pant." So it's moderate intensity exercise, 2.5 hours a week, proving to be beneficial both for the motor aspects of the condition and certainly not and for the non-motor aspects, things like the constipation, things like the sleep disturbance that is experienced. So the role of specialist nursing. Internationally, the role of specialist nursing has been studied by Lowe and colleagues, and what they said was that the nurse is significant in being able to continue the clinical monitoring of the condition. And there they have prescribing rights, so they can often make adjustments to the medications. It is critical that they are that continuing point of contact and they can be involved in home visits. They become a reliable source of information, and it certainly tells us that it's a very valued, cost-effective system. Those same things have been actually found locally in a study that was undertaken interstate by Bramble and colleagues. They investigated the benefit of having Parkinson's disease nurse specialists in regional areas, and what they found was that there was significant benefit to patients and healthcare systems as a result of that, and I'm really rushing now, please forgive me. So, as I mentioned, my research interest is around the development of interdisciplinary models of care. It stems from the fact that there is inequitable healthcare, particularly around Parkinson's disease, for people who live in regional environments. So what I'm trying to investigate is what would an interdisciplinary model of care look like for regional environments, and how does that support a person with Parkinson's disease live well? We're also having a look at one of the non-motor aspects that are related with the condition, one that I haven't mentioned yet, and it is pain. Pain is a significant feature for people who live with the condition. So we're conducting 2 other studies particular to the young onset Parkinson's disease group, people who are less than 50, 45 years of age, and for others, what is it that prevents pain being assessed properly and managed properly? So, we're just about to hit World Parkinson's Day. It is on the 11th of April. On that day, let that be a little prompt to say, what do I do personally that might support the development of generating new knowledge for Parkinson's disease? What is it that I can contribute? And I've rushed the last little bit, but I certainly appreciate the time that you've taken to come and learn more about Parkinson's disease, and I certainly appreciate your attentiveness this afternoon.
So we'll just see how we go.
I'm just wondering, with the use of the infusion pumps, does that only happen at the stage where the person is no longer able to swallow safely, or for some other reason can it be used earlier?
As the disease progresses, one of the things that becomes obvious is people start to have fluctuations in their motor and non-motor symptoms. We think it's related to, often medications are prescribed so that the concentration that's floating around in their blood stays within what's called a therapeutic range. Yeah? So if you were to offshoot that therapeutic range, you'd have adverse effects related to being over-medicated. If you undershot that range, you'd not get the symptom relief that you were requiring. What appears to be happening in Parkinson's disease, and we're not quite sure why this is so, is that therapeutic range narrows over time. So people start to have some difficulty or experience fluctuations and adverse experiences related to their medications. What we can do when we give those infusion therapies is, because we give a smaller dose but over a longer period of time and it happens continuously, sorry, I'm moving away from the microphone, we have a way that we can actually prevent or manage some of those fluctuations in symptoms, because we can start to get that concentration back to within that narrowed therapeutic range. So it's useful for that, and that tends to happen a bit further down the track when you've been living with Parkinson's disease. So yeah, here it tends to be prescribed a bit later in the journey.
Another question near the front, I think, Jay, just down here. Thanks.
Thank you, Sue. Fabulous talk. Pat, with the Parkinson's nurse, because I know with other conditions, sometimes people haven't, the GP might not have brought up the topic. So if a person's been diagnosed, been to a specialist, etc., and is at the beginning of their journey, at what point would the Parkinson's nurse would it be good for them to start interacting with the Parkinson's nurse? And whose responsibility is it, the GP or the specialist? Or
it's really a tricky question, because our system here in South Australia is developing. You know, in countries, US, Canada, the Netherlands, they have well-established interdisciplinary systems, and they have networked healthcare systems. So what happens in an acute care hospital, for example, there's a team that exists there and a team that exists in the community, and there's great communication that occurs between those teams. We're still developing that here, and often we're not yet at the stage where we're truly working in an interdisciplinary way either. So my suggestion around that would be is, as soon as diagnosis occurs, there are Parkinson's disease nurse specialists that exist with the Hospital Research Foundation Parkinson's group, and I would make myself known to that group, because if it is that you're struggling to have your first appointment with the neurologist, or you're during that phase between appointments with your specialist, it might be an issue that can be managed with some education or some advice from the Parkinson's disease nurse specialist. So I would do that as soon as diagnosis occurred. Yep. You might meet them if you're going through the public sector. You might meet them in some movement disorder clinics. They do exist in some of our movement disorder clinics, but otherwise there's the Hospital Research Foundation. Yeah, at the beginning. Yes.
Jay, just immediately adjacent to you there,
Hello, thank you. With the people that I know with Parkinson's, sleeps and everything that goes with lack of sleep seems to be a really strong factor in the debilitation of that person.
Yes.
So where do those people go for specific help around sleep, or is there none?
There is some, and that's the sort of thing where those interdisciplinary members might offer some advice. Occupational therapy can certainly offer some advice, and the Parkinson's disease nurse specialist, they would help unpack that. They would help understand what is the sleep disturbance that's occurring. And then they would coach people on what we call sleep hygiene. So what are the habits that are necessary for you specifically that might help you formulate a regular sleeping pattern? So all of that requires assessment, education, coaching and ongoing monitoring. And often a Parkinson's disease nurse specialist will be very useful for that sort of management.
Any other questions? No, it looks like, well, I know that you will agree with me, this has been a really excellent session, very clear, very informative, and so relevant, because we all know someone with Parkinson's, living with Parkinson's disease, if we do not have it ourselves, and the prevalence is only going to increase. So thank you both.
Thank you.
Please come up, if you will, Gabrielle, and that we can thank them, and I'll give them something which I don't think is just destined to aid Parkinson's symptoms, but when enjoyed in moderation, you'd hardly know just what.